Thank you. So my name is Crystal Dennis. I'm coming to you from Dorset in the south of the United Kingdom. My role here is to lead the public-facing digital health technology agenda. And so I'm going to talk to you about how we're approaching it here in Dorset with our population and how we're approaching it with the financial and the workforce limitations that we currently face. On your screen at the moment, you will see that these are the barriers that we're coming up with digital innovation and transformation. So very much around our workforce and our population being made aware of what they can access, how to access digital health technologies, helping the workforce and the population trust what is available to them, and making sure that this is done in a coordinated way. So I just want to reinforce that even though I'm here to talk to you about digital or mobile health, that actually the agenda here in Dorset is very much around all of our digital programs working together in a system approach. So each will have its own benefits and its own outputs, but it's only by working together that we are going to collectively achieve the cultural transformation, both in behaviours and in the digital investment and with our workforce in order to achieve the health outcomes and deal with some of the problems that we have. So we have something, a programme or a theme around infrastructure and our enabling technologies, very much around our bandwidth and our cyber security and our data protection. And then we also have our interoperability piece, which is just down here at the bottom. This is very much around our shared cared records and making sure that the hundreds of systems that we have actually talk to one another. And then we also have the use of our business intelligence for secondary use, so our population health analytics. This is where we've joined together our general practice data, so our primary care data, our community mental health and our acute data, in order to understand our population and their behaviours a little bit better, and it powers our population health insights. And then, of course, there's the programme that I lead around digital health. None of this can be done without full working with our workforce systems around digital readiness, with our population around their digital literacy skills so that we're not leaving anybody behind, and research plays a huge part into this agenda. So in the themes that you can see here, there are two very clear processes. One is around efficiency, and that's how our workforce work. And one is around culture change and the transformation piece that often gets missed when we're looking at things from a digital project management piece. So the problem that I'm trying to solve here in Dorset with our team is around our population health analytics and re-establishing the way that our population interacts with our health and social care system. So it's taking a personalised approach, using a digital first approach where appropriate, and using the technology to act as an elastic band around our health and care teams. So I know that regulations and the legal aspect tends to be an ongoing theme in all of these discussions. But actually what you can see here is that here in the UK, we've understood that not all digital health technologies are the same, and the regulations change according to the purpose of the technology. And we have 4 different levels of those here in Dorset. One of them is around prevention, and these are standalone applications or digital health technologies, things like step trackers, fitness trackers, diet apps. So they don't necessarily sit within our pathways. They're there for people to use as part of the prevention agenda. And we know that in the Android and App Store, there are nearly 400,000 digital health technologies or apps that a person could choose from, but less than 2% of them have actually been proven to be clinically assured. So we want to make sure that we are educating our workforce and our population around which ones are safe to use. And I'll talk about that a little bit more later. So we have apps that sit in the prevention agenda. Our second level is around integrated digital health technologies. So these might be some communication platforms, things like platforms that power your texting or your email or your video conferencing. It could also be things like symptom checkers or mood diaries. So these are ones that are kind of supported by the care team. They might be able to see the data that sits behind them or what the patient is contributing into those front end platforms. We also have a third level, which is around pathway replacement. These are very much linked to things like mole checkers. They usually have some type of machine learning or AI that sits behind them. So mole checkers, blood pressure monitoring, ECG monitoring, things that you could use your device or use a device with a split level app that could feed back into your clinical teams. So very much around the remote monitoring agenda. And then we have our fourth level. These are quite heavily regulated. They're usually the personal health records, so they're administrative support. So they would visualise our clinical correspondence through to a patient, or they would allow a patient to book into their care setting, or electronic repeat prescriptions. So it's by using all of these together in the appropriate format and applying them in the right way that we end up making a change to the pathway. So those are our four areas that are regulated differently. And that's part of the knowledge exchange that we do with an awful lot of our clinical teams in the first instance. So whenever we are looking at digital health technologies, either in apps or wearables, we're very much looking at four themes in this regulatory puzzle that I just went through with you. There's very much a data privacy and security issue, clinical assurance, and user experience. And what we recognised is that every time we were going to be looking or recommending or signposting either a patient or a member of the public to one of these technologies, we wanted to make sure that there had been a full evaluation so that if it does require them to put their data into it, it was safe. And that it was clinically assured and still had a good user experience. No point in using a technology that has a good user experience but doesn't keep somebody's data safe. And so we needed to make sure that we worked with a partner that could do that in real time for us. For instance, one of the technologies that we use here around long-term condition management in Dorset has had 20 developer updates over the last 12 months. And so we use a partner that does the evaluation. They will pick up on the Android or App Store every time a developer does an update, and they will go in and they will evaluate the update or the change that has been made so that we are again always mitigating our implied liability or chain of indemnity for our clinicians in real time. So we're trying to mitigate that risk as best as possible. So in our digital health agenda, we realise there are building blocks. There is no one particular technology or platform that is going to deliver the vast amount of requirements. These requirements come from various clinical teams from various parts of the system. The stakeholders that use them would be different. And so we've accepted that we're going to need to be able to work with many industry partners and lots of different technologies. And it's actually the architecture that's going to bring that together. So the absolute foundation of our building blocks is around our digital health information. And that at the moment in Dorset is powered by 3 platforms. We have a health app library, we have a video library, and we also have NHS UK, previously known as NHS Choices, and that's regulated here by the NHS England and Improvements group. On top of that, we have our online triage. That's our eConsult platform powered by our industry partner eConsult, and that really allows somebody to complete an electronic form and make a request through to either their GP or their clinical workforce in primary care. And that could be returned either by a video consultation from the GP, they could make a response via an email, or they could make a response by an SMS or a telephone. And of course, they would draw down from the platforms in terms of signposting and education patients for self-management from the building blocks with our app library, video library, or NHS UK. Sitting on top of that, mainly done by our nursing and our advanced nurse practitioners, is around our long-term condition management. And we were looking at COPD, asthma, heart failure, and diabetes. And they're very different, those platforms. They are there around accelerated access through to things like pulmonary rehab or cardiac rehab, being able to assess and view a patient's trend analysis of the data that they are putting into those portals on a regular basis in order to be educated at any time of the day, whenever they feel that they need to, without worrying about making an appointment with their clinical team, and then being able to manage their care and coordination. So we look at these around patient-initiated follow-ups. So these are types of technologies that, even though there is a clinical portal that sits behind those front-end apps that allows the clinical teams to be able to caseload or to see all of that patient-contributed data, but there is no expectations for them to be doing remote monitoring of the patients that use those. If they choose to do caseload management, they can do, but in this developing piece of digital health at the moment, some of the teams just aren't ready. So we look at those types of population in two different categories. One of them is around the rising risk of the population, and one of them is around the highest risk of the population. And according to the way that they take care of themselves, their age, their wider determinants of health, they might go in and out of those groups. So that's our long-term condition management. And then we've heard a lot around personal health records today. So again, those are like those administrative platforms, regulations. So we have one here in Dorset, and it's like a digital passport. So it means that the patient can take an electronic form of all of their contributed data and clinical correspondence with them to anywhere that they are in the world or in the UK. They can contribute to that, and it will be fed back into our summary care record or our clinical portal that sits behind that. And actually it's the personal health record and their team that architecturally are responsible for bringing all of those patient portals into one area so that they can have a single point of navigation for the population. And then we move more into the area of remote monitoring. So these are digital health diagnostics, things like pulse oximeters, blood pressure monitors, and screening tools like urinary analysis being done from home. So these platforms are medical device regulated softwares that truly allow a visualization of all of the patient contributed data in a RAG rated so that you can have a true virtual clinic. And we are using those types of platforms at the moment for COVID monitoring of patients at home so that we can identify deterioration of them earlier wherever they may be in a community or home setting. And of course, there is a lot of data mining that sits on top of that with artificial research and machine learning. So that's how we categorise the different types of technologies here in Dorset and how we apply them within the care model. So whenever we're looking at a platform, we will take a population health approach using the analytics that we have available to us, and we will look to develop those further in each one of our projects. And of course, that sits within a separate part of our digital transformation programmes. That's around our business intelligence. And so all of the data that I use from these technologies is fed back into those platforms so that we can get more of an understanding of the digital behaviours of our population and also ensure that we're not increasing health inequalities, we're not widening the gap or access through to services. So this is what it looks like at the moment. We have long-term condition management portals around diabetes, asthma, COPD and heart failure. And the reason why we have chosen that is because with a population health approach, we know that if you develop one, you can develop more than one of those conditions. And we're not going to be asking patients at the moment. We do not have the technical architecture, enterprise architecture or design to bring different platforms together with the same user experience. That's an ongoing piece of work. And so we work at the moment with one provider that covers all of those conditions. We are working with another provider that specialises in oncology and the risk stratification of patients with cancer, particularly breast and colorectal, so lower GI and upper GI cancers. And then we also have a maternity portal for those that are going through their pregnancy. So again, these are all areas where we have a shortage, particularly in our cancer teams, we have a shortage of specialist consultants. And so it's a way of us being able to manage the population and get them access through to the correct services. So we use a different way of utilising the workforce that all have access to the patient contributed data that sits behind these portals. On the left-hand side here, you've got the digital health information. That's the absolute building blocks. And this is what our video library and our app library looks like. And then we've got some of the projects that we're looking at from the diagnostics or the remote monitoring from home. So you can see a blood pressure cuff and a pulse oximeter there. We also have for our diabetes pathway, a urinary analysis screening tool, which is around our ACR. So these are a type of protein that is searched for in the urine, the population with diabetes do need to have an ACR check on a yearly basis to help identify if the patient's moving into chronic kidney failure. And actually, as a system, it's one of the checks that doesn't always happen. Just purely because either patients don't have time to do it, or they haven't dropped their samples back into surgery. And of course, statistically, what happens with that cohort of patients is that they end up moving through the 5 stages of degenerative kidney disease, and at stage 3, they will end up mostly being conveyed in a crisis form or for an inpatient stay because they haven't been on the correct medication because it hasn't been identified. So we're looking at increasing compliance to the NICE guidelines by making sure that those checks are done on an annual basis. And we're actually looking at the application of those checks within our hypertensive population at the same time. So in the centre there, you've got our personal health record that is tethered or linked through to our summary care record in Dorset. It's called the My Dorset Care Record, and it is architecturally responsible for bringing together all of those digital health platforms into one user experience. This is how it looks like from a care model perspective. So patients that are looking to gain access through to their clinical teams would complete an online triage, an online e-form, either through the NHS app that's been made available to us by our national teams or through the practice website. It goes through the administrative workflow. A clinician will review that within 24 to 48 hours. They will either then online message to the patient via an email, they will do a video consultation, a telephone consultation face-to-face, or send a text, and they will signpost either using one of the platforms for education in a supported self-management way. On the right-hand side, you've got some of the branding of the platforms that we use here in Dorset. And then if a patient is or does have a long-term condition, again, we will use a digital health coordinator in order to review that virtual clinic data, and will escalate appropriately through to a nurse or through to a doctor, dependent on the risk of the patient. So some of the things that we have noticed around our workforce when we've been looking at developing this agenda is that we needed to have a community of practice in order to keep the chain of communication between what was happening centrally and how it was being applied. So we have developed that, and we have regular webinars with those groups. They could be GPs with specialist interests, consultants, nurses, healthcare assistants, or even admin coordinators that take on or are in an apprenticeship. And again, we're trying to repurpose any releasing capacity to the workforce in order to provide better care for those that are at the highest risk of the population. And for those where administrative purposes are being streamlined, there's the offer of apprenticeships going forward. We have clinical implementation groups, and again, those are different dependent on the subject that we're dealing with or the project at hand. We also have brought all of our patient portal groups together. So cancer, the long-term condition management, hypertension, COVID at home, they all come because they'll all come up against the same challenges. And we're developing our workforce by realising that a care coordinator should be a digital health coordinator or advisor, because the onboarding of these technologies and the constant iteration of the use of them does need to be done at light touch, doesn't necessarily need heavy clinical involvement. It's more about moderating it and keeping it in regular use. And that can be through a reward or through a nudge to the patient, either using the portal or through an SMS text message. And of course, in digital in general, we have to break down the barriers around awareness and accessibility and trust. And by helping those barriers be broken down, we've made available fellowships, digital fellowships, multiple ones for any part of the clinical team or operational teams, because you build that type of experience over time. We're also making good use of our clinical safety officers, because the hazards of all of these, clinical hazards of these coming together is becoming more complex because of the dependencies between all of the technologies and the use of those, both for either research or for secondary use in our population health analytics or for decisions at point of care. And so we've had to invest time and money into clinical safety officers, making sure that we have enough of them, fellowships and clinical chief information officers, whether they be consultants, GPs, allied health professionals, nursing teams, but we've had to make sure that we have provided the fellowships in order for them to build those experience with the core specialists. And then we know that we need to make ongoing training and moderation, because the transformation and the change management that sits behind all of these platforms doesn't happen overnight. We have certainly recognised that you can't just deploy something and expect the workforce or the population to take that on automatically. It takes time, and actually it's all of the business intelligence and data that sits behind it that shows us whether we're actually developing that knowledge and that capability within the teams, and that whether it's being applied properly, and that's shown in the ongoing use of those technologies going forward. So as a system, some of the technologies we're building ourselves. Our personal health record, we are building ourselves. And so we have ongoing recruitment for testers. We definitely work with our community and our charity and our third sector organisations to create more of a room within our workforce around the adoption and the awareness, and also to support the digital literacy development so that we're not leaving anybody behind. And then also to make sure that we're double checking our designs back with our population and that they're happy in the way that we're taking things. So I'm going to stop sharing there because that is the end of my presentation. Any questions?